Okay, well thank you everyone. I've been asked to talk today about the health effects of smoke from wood heaters, and particularly to talk about what the current state of the evidence is about that. People often perceive wood smoke to be something natural, something with a lovely smell, and I often hear a wide range of views as to whether that's simply a nuisance or whether it is more harmful, or if it's a major health hazard, or can it possibly be fatal. So what I'm going to do is go through the evidence regarding those things. Firstly, I'll describe what I mean when I talk. I often use the term biomass smoke, and smoke from wood heaters is an example of biomass smoke. That term refers to the emissions that are given off when biological fuels burn. So it's the smoke that comes from burning vegetation. Bushfire smoke is a good example of that. You can see on the slide a picture from the Canberra fires of 2003. Wood heater smoke, outdoor chimney smoke is another example, as is indoor smoke. A lot of people, particularly in low-income countries, depend on fuels for cooking. Indoor smoke is a big problem, particularly with poor ventilation. And the other major source of biomass smoke in our community is actually tobacco smoke. And in the context, environmental tobacco smoke is quite comparable to outdoor wood smoke. So they're all very similar, biomass smoke. The constituents vary depending on what's been burnt, but because they're all organic, they've got a lot of organic compounds. So there's a 200, 300 chemicals in all sorts of, in smoke from all biomass sources, and it's pretty similar between environmental tobacco smoke, wood smoke and bushfire smoke. But just in brief, particulate matter is the main and biggest component. They're listed here on the slide. But there's a whole range of organic compounds, and a lot of these have been studied in detail, and a lot of them are known to be irritants of the respiratory system, or they're known to be carcinogenic or to promote inflammation, and particulate matter has been associated with deaths and admissions for heart and lung disorders. How do we know all this? There's two different types of studies. Toxicology studies are experimental studies. A lot of these are done in animals, but some are done in humans, and this is a picture from a slide of an experimental exposure of healthy volunteers to smoke from a wood heater. So it's a very controlled, short exposure, and then the volunteers have measurements taken of their blood, clotting, inflammation, their lung function, and that's compared with breathing clean air and breathing wood smoke. These studies are very useful. We learn a lot from them, but they don't actually tell us what goes on across a whole city or a community that might be affected by outdoor wood smoke. Those studies tend to be more observational rather than a deliberate controlled experiment, just because the constraints of what you're able to do. And epidemiological studies are the sort of studies that have largely been done to work out what the public health effects of wood smoke are. And just as an example, this is from some work my team did in Launceston, and on this slide the blue wiggly line across the middle shows the daily death rates in Launceston, Tasmania from 1994 to 2008, and the little grey dots that you can see across the bottom, and some of them reaching up towards the top of the slide, they represent the daily average concentrations of particulate matter, which, as you can see, every winter they rise quite high, and that's largely due to the emissions from the wood heaters in Launceston. And it's by comparing data such as this and taking into account other factors such as influenza and the ageing population, epidemiologists can put together what the level of exposure is and what the outcome is in terms of death rates, and work out what sort of effect smoke might have on community death rates. So from these sorts of studies, the evidence about wood smoke exposure is actually very strong, and as more evidence comes in, it's actually looking more and more like what we know very well from studies of people who smoke cigarettes. It's simply a difference really in the amount of exposure and the duration of exposure. So we know, for example, that exposure to wood smoke is very strongly associated with making respiratory diseases worse, particularly making asthma and chronic lung disease worse. We know it increases infections of the respiratory system, including pneumonia and including ear infections. We also know from direct comparative studies that the same concentrations of particulate matter tend to cause greater respiratory effects than the same concentrations of particulate matter that comes from traffic exhaust and urban air pollution. So biomass smoke seems to be worse than traffic pollution as far as respiratory health goes. There have been fewer studies done of heart disease and of deaths, but the few studies that have been done point to a similar impact on heart disease, increasing inflammation and increasing blood pressure, making the blood more prone to clotting. There's some effects that have been documented, and also increased hospital admissions for heart diseases. Impacts on mortality have also been studied in big bushfire episodes and in cities where there's a lot of air pollution from wood smoke. And again, strong associations have been found with all-cause mortality, respiratory mortality, and mortality from heart disease. And in some cases, infant mortality. That was documented in the extreme exposure experienced in Indonesia during severe fires of 1997. About 1% of the birth cohort was lost. It was reduced by 1% attributable to the smoke from that event that went at extremely high levels for 3 or 4 months. So we know that there are these direct associations with wood smoke. I guess the next question is, what can we do about it? Is it worth trying to improve air quality in communities that have poor air quality? If air quality is not too bad, is it worth trying to improve it some more? Will there be a public health benefit from that? And to learn about that, we need to know about evaluations of other interventions that have been done. That's the best direct evidence for if it works. And examples of good studies of interventions are hard to find, but in the last 12 months or so, there have been 2 that have been published. And there's probably 10 or 12 published across the spectrum of air pollution, but 2 have specifically been about wood heaters and about concerted community efforts to reduce the smoke from wood. The first took place in Libby, a small community in Montana in the USA, and the second one was here in Tasmania in Launceston. And just briefly, this figure is from the publication about the study of Libby, and the pale grey line shows the percentage of wood heaters that were either removed or changed from a highly polluting sort of wood heater to a much less polluting, more efficient wood heater, or a pellet stove, or another kind of heating that didn't involve burning biomass. And this community only had a population of 2,000, and they were able to change out and improve 98% of all wood heaters in that community. And the black line there shows the summer-winter air pollution concentrations as they fluctuate. And you can see by looking at that that in the 3 years after the change out, the peaks, the winter peaks in particular, are not as high as before. So they certainly had an impact on air quality. And I'll just show you this slide from Launceston again. As I said, the blue line represents daily death rates and the grey dots represent pollution. And the black lines there represent the average pollution, measured here as PM10, each winter. And there's a dashed red line down the middle, which marks the start of a lot of intervention programs in Launceston. And that, again, you can see, particularly if you look at the winter average pollution, you can see the substantial drop in winter pollution. Okay, so what was the outcome? In Libby, the scientists there did lots of studies of air quality, but they also set up a prospective study of children's health, and they surveyed parents for 2 years before the interventions and for another 2 years after. And they asked parents about how often their children had symptoms of wheezing, had a cold, had bronchitis, influenza or throat infections. And they compared the results before the intervention with the results after the intervention. And I should say that the PM 2.5 dropped 27.6, so it was improved by about a third. And what they found was that a 5 microgram per cubic metre decrease in the PM 2.5 was associated with large reductions, and these were all statistically significant results, in all these measures of child health. So wheeze, the prevalence of wheeze fell 27%, colds 25%, bronchitis and influenza about 50%, and similarly for sore throat infections. The other study was done in Launceston, Tasmania, a much bigger town. The population that was studied was the central part of Launceston, the people who live in the river valley, which is well known for its problems of inversions and trapping of wood smoke. And the interventions there were threefold really. There was a wood heater replacement program which saw a lot of people change from wood to electricity to heat their homes. The prevalence of wood heaters fell in half, it was cut in half roughly during that time. But there are also community education programs and specific education programs associated with looking for particularly smoky chimneys and targeting the education to the households that needed it most in terms of emitting smoke. And so as a result of that, not only were the numbers of heaters reduced, but the operation of heaters was improved. And there was a fantastic improvement in wood pollution, air pollution from wood smoke. The PM10 was reduced on average by 40% after the interventions as compared with before. And when our team looked at death rates in Launceston, we found that during winter, deaths due to heart disease were reduced by 20% and deaths due to lung disease were reduced by 28%. These deaths in winter, statistically numbers are small, so these were just on the borderline of statistical significance. When we looked across the year, we had highly statistically significant results in men, but not so much in women. And that's probably a function of the small numbers studied and possibly a function of the fact that more men smoke and might be at risk of heart and lung disease than women. In absolute numbers, the percentage falls were quite substantial. It translates in the population of Launceston to about 30 premature deaths that were avoided each year because of the improved air quality. So just to summarise, what we learnt from these two studies in particular is that coordinated interventions can certainly have a major impact and improve air quality substantially. And we learnt that improved air quality will improve children's health and it will save lives. We know from the literature that we can expect improvements right across the spectrum of health effects that are attributable to air pollution. We know that it tends to be a linear or a dose-response relationship, so the higher the pollution, the worse the effect. It means that if we saw these benefits with air pollution falling a little bit, we'll see a whole lot more benefits with air pollution falling a bit more. And just to remind you of the spectrum of impact across a community, when a whole community is affected by poor air quality, everybody gets exposed. There's no way we can avoid dealing with the air that we breathe. And everybody will have a response to that, a physiological response. It will stress our systems in some way, increase inflammation, increase blood pressure. And most of us will tolerate that just fine if we're fit and well. But there are a lot of people who are already at risk, who already have lung disease, who might have some heart disease. And it's in that group of higher risk people who might get symptoms. They might get lung symptoms, asthma might be made worse, someone with heart disease might have progression of their disease, they may not get a symptom. And then a smaller proportion of them, again, will get ill to the extent they need to see a doctor or they may be admitted. And deaths are really the tip of the iceberg when it comes to the impacts of pollution. So finally, to return to my original question of whether wood smoke is a nuisance or a health hazard or fatal, the state of the evidence that we know, it really is all three, and whether it's one or the other depends on a range of factors. It depends on the individual concerned and their level of risk. Many people will tolerate, healthy people will tolerate smoke without any trouble at all, but if they're in a higher risk group, that very same exposure can cause serious illness or can be fatal. So that partly depends on the individual, and it also depends on the concentration of smoke, the level of pollution in the community, and how long it's experienced for. Thank you.